Hello, everyone. Our group is going to be presenting on the topic of THC, as well as a possible use case for it as an anti-inflammatory medication. Presenters for today. And to kick things off, we're going to start with a short history of THC.
Cannabis was found more than 5,000 years ago in Romania. There is only one direct source of evidence that cannabis was used medicinally, and that was around 400 AD. In the United States, cannabis was widely utilized as a patent medicine in the 19th and early 20th centuries. It was described in the United States Pharmacopoeia for the first time in 1850. Federal restriction of cannabis occurred with the passage of the Marijuana Tax Act. Subsequent to the Act of 1937, cannabis was dropped from the United States Pharmacopoeia in 1942, with legal penalties for possessions increasing in 1951 and in 1956 with the enactment of the Boggs and Narcotic Control Acts, respectively, and prohibition under federal law occurring with Controlled Substance Act of 1970. Beyond criminalization, these legislative actions contributed to the limitations on research by restricting procurement of cannabis for academic purposes. In 1996, California became the first state to permit legal access to use of botanical cannabis for medicinal purposes under physician supervision. Marijuana is recognized by the United States Drug Enforcement Agency's, DEA for short, Comprehensive Drug Abuse Prevention and Control Act of 1970 as a Schedule I controlled substance, defined as having a high potential risk for abuse, no currently accepted medicinal treatment in the United States, and a lack of accepted safety data for use in medicinal treatment in the United States, and a lack of accepted safety data for the use of treatment under medical supervision. THC, which is short for tetrahydrocannabinol, is the major psychoactive component in marijuana. Delta-9 tetrahydrocannabinol is the compound that is most responsible for the intoxicating effects, and this chemical is found in the resin produced by leaves and buds of the primarily female cannabis plant. The plant produces around 500 other compounds, 100 of which are considered cannabinoids, which means they are chemically related to THC. The main routes of administration are inhalation, oral, sublingual, and topical. THC's synthetic formulation, dronabinol, is FDA approved for nausea caused by chemotherapy. THC is also FDA approved for appetite stimulation in HIV and AIDS. THC, however, is not considered a monotherapy for the two conditions. THC is also relatively safe and has few deaths. There is also no known THC overdose. However, medicinal cannabis may pose similar health risks associated with its use, including psychoactive, intoxicating, and impairing effects, which have not been completely elucidated through clinical trials. Physicians should assess for psychiatric or cognitive impairment associated with THC use and be aware of interactions with drugs of similar effects. Hemodynamic changes also require monitoring after administration. Patients should be informed not to operate motor vehicles or heavy machinery until reasonably certain that they are not impaired by THC. There is a risk of dependence and misuse, which also must be assessed by the physician, especially in patients with a history of substance abuse or dependence. As seizures or seizure-like activity has occurred in patients using THC, care is necessary when prescribing patients with these kind of risk factors or a family history of seizures. Anti-inflammatory treatments, however, are still under research and are considered experimental.
THC is used to manage inflammation. Inflammation occurs as a result of the body's white blood cells, protection from pathogens and infection. As a result, blood flow to the area of infection increases, causing redness, warmth, swelling, and pain. Inflammation can be categorized into acute and chronic. Untreated acute inflammation can lead to chronic inflammation lasting for a longer period of time. Inflammation can affect vital organs such as the heart, leading to myocarditis. In the kidney, it can result in nephritis. In the lungs, it can cause pneumonia, and in our joints, it can cause arthritis. THC has an immunosuppressive effect to manage inflammation without any psychotropic effect.
For THC mechanism of action, the cannabinoid is produced by THC, and the cannabinol binds to cannabinoid receptors within 3 places in the brain. These 3 places are basal ganglia, cerebellum, and hippocampus. The cannabinoid receptors are usually activated by the neurotransmitter and a natural cannabinoid produced by body called anandamide. And THC mimics anandamide and binds to cannabinoid receptors to activate neurons in brain, which affect the sending, receiving, and processing parts of cell communication, and ultimately affecting the mind and the body. The two main actions of THC is mimicking or blocking actions of neurotransmitter to interfere with normal function. Compared to other neurotransmitters, cannabinoids work backwards. Normally, neurotransmitters are released from a presynaptic cell and attached to the receptor at postsynaptic cell, causing signal transduction. However, cannabinoids are made from lipid precursors when postsynaptic neuron is activated, and once they are released from the lipid precursor, the cannabinoids travel backward to the presynaptic neuron, allowing them to attach to cannabinoid receptors. There are 2 kinds of cannabinoid receptors, CB1 and CB2. CB1 receptor is the main receptor of THC, and it is one of the most abundant GPCR in CNS. And high levels can be found at hippocampus, basal ganglia, cerebellum, and brainstem. CB2 is mostly found in cells and tissues of immune system, and it is mainly responsible for anti-inflammatory effects. THC can cause diverse side effects, but some notable short-term side effects are short-term memory loss, severe anxiety, hallucination, and lower reaction time. And some long-term effects are decline in IQ, addiction, and impaired cognitive skills. And as of any other addictive drugs, THC can also be the target of prescription abuse. Some methods of abusing prescription are taking larger dose than prescribed, and saving dose for later use, and increasing frequency of drug consumption, and using with other substances. As pharmacists, we have to be wary of these situations and guide our patients to have best health outcome.
Okay. Hi everyone, my name's Chris, and I'll be going over a short review of the efficacy of cannabinoids as a novel anti-inflammatory medication. So, first things first, where does everyone stand, right? So, marijuana is still illegal in parts of the U.S., and in the eyes of the American Medical Association, it's viewed as a harmful substance. For pharmacists, we like to think of it as tobacco and alcohol. We all know them to be unhealthy, but occasional use won't kill you. So usually we recommend against long-term habitual use, okay? And then as for the scientific community, so where does everyone stand there? So quite honestly, it's still in question. While there are many meta-analyses, there are still few randomized controlled trials and even fewer that yield consistent data. So simply put, there just isn't enough data. There is still hope though. While there isn't an exhaustive list of randomized control trials, there is still enough data for us to understand there is a potential for THC to be an effective and safe medication for many rheumatologic diseases through its anti-inflammatory mechanisms of action. So I'm going to be going over a couple of studies, specific cases that had indications and points to be hopeful for, that THC could be indicated for anti-inflammatory diseases. So first things first. As we've seen, THC acts through both the CB1 and CB2 GPCR receptors, but through CB2 in the periphery, it offers anti-inflammatory effects through the immune system. So we've seen some cases where evidence points to studies that show cannabinoids actually downregulate cytokine and chemokine production and upregulate Treg cells in a way to suppress inflammation. In other cases, we've seen THC exert its effect through the induction of apoptosis, inhibition of cell proliferation, and again, more evidence to suggest that it will decrease cytokine production and induct Treg cells. In our next study, we have Dr. Ting and group who demonstrated ABK5, which is a selective agonist that mimics THC on the CB2 receptor to suppress inflammation. And it did this by demonstrating that it actually decreased concentrations of interleukin 10. One thing to note, though, so interleukin 10 is a anti-inflammatory cytokine. On the other hand, the study also pointed out that concentrations of interleukin 8 also increased. And interleukin 8, if any of you recall, is a pro-inflammatory cytokine. So again, this kind of points back to data being inconsistent, right? There are cases where it is indicated for inflammation, and there are cases where it's indicated for anti-inflammation. In our last study, essentially, we're comparing the efficacy of methotrexate and delta-9 THC / sesame oil for the treatment of RA. So the results suggest promising effects for the clinical use of delta-9 THC and sesame oil therapy in alleviating arthritis clinical signs, as well as preventing arthritis-induced liver injury, which is pretty common with methotrexate. So essentially, it's a drug with less side effects, which is always welcome. Even with the data that we have and all the randomized control trials, meta-analyses, etc. Simply put, we just need more research. We need to research the entire endocannabinoid system, its potential targets, synthetic analogs, which some are approved by the FDA right now, as well as combination drugs that we can use with THC, and how it will impact facets of human diseases. And I will leave our references at the very end. Thank you.